When a person suffers an out-of-hospital cardiac arrest, or OHCA, where the heart stops completely outside of a medical facility, the baseline reality is grim. Across the globe, standard survival rates sit firmly under 10%, and the clock is unforgiving. If standard chest compressions continue past the 15 to 20-minute mark without restoring a heartbeat, the patient enters a refractory phase. At this point, the probability of surviving with your brain function intact drops to roughly 2%. The conventional response is to load the dying patient into an ambulance and rush them to an emergency room. But a radical alternative approach flips that logistics model entirely. It is called ECPR, or extracorporeal cardiopulmonary resuscitation. Instead of bringing the patient to the hospital, an emergency team brings a VA ECMO machine, a complex portable heart-lung bypass system, directly to the street. To see if this aggressive intervention could actually work as a reliable standard of care, researchers in Regensburg, Germany, conducted a 10-year observational study. They fully integrated a specialized ECPR team into their regional 911 dispatch system. This infographic highlights the study's primary findings, and the top-line result is striking. Of the 213 patients treated with this street-level bypass, 34.7% survived to hospital discharge. That vastly outperforms traditional CPR outcomes. That survival rate is the direct result of a ruthless, data-driven elimination process. The system is engineered to isolate and treat only the absolute perfect candidates. Over the decade-long study, the local emergency dispatch center received 11,235 calls for suspected or confirmed cardiac arrests. That massive number forms the top of the triage funnel. The dispatch center operates on a dual alert system. The moment a severe cardiac call drops, regular paramedics are dispatched, but a specialized ECPR team is simultaneously put on standby. They're racing against a strict 45-minute viability window, the maximum time allowed between the heart stopping and the bypass machine turning on. Immediately, the dispatcher begins filtering. More than 8,500 cases are instantly rejected over the phone. If the patient is over 75, under 18, or has known severe pre-existing illnesses, they are disqualified from the experimental bypass program. The procedure is too demanding on a frail body. That leaves 2,655 cases. For these patients, the specialized ECPR team is officially deployed to the scene to evaluate the situation with their own eyes. Surviving this initial telephone does not guarantee treatment. It simply advances the patient to a much more rigorous biological test, conducted right there on the pavement. Upon arrival, the doctors must briefly detach from the chaos of the scene and act as objective data scientists. They are scanning the patient's body for specific, measurable predictors of mortality. Looking back at the study's graphic, we see the exact red flags they hunt for. If bilaterally dilated pupils are unresponsive, it multiplies the odds of a fatal outcome by nearly 6 times. Next is the bystander effect. The absence of immediate CPR by a layperson within the first 10 minutes raises the odds of mortality by a factor of 4.4. Finally, if the initial heart rhythm is asystole, a complete flatline, the odds of death jump by 35 times. Prolonged use of mechanical CPR devices also severely compromises eligibility. This biological filtering is extreme. Out of the 11,235 initial emergency calls, only 213 patients passed every test. That is roughly 8% of all on-scene evaluations who actually received the bypass machine. For those 213 approved patients, the medical team initiates an intense logistical strike. They must surgically insert thick ECMO tubes into the patient's major blood vessels, effectively establishing a sterile operating environment right on a public street. This is an incredibly delicate procedure. Over the 10 years of the study, the team learned that utilizing portable ultrasound devices during these street cannulations was mandatory. It dropped their complication rates from nearly 22% down to just 9%. Successfully connecting the tubes to the blood vessels is a technical feat, but it is medically useless if the team fails to beat that 45-minute window or if they ignore the biological red flags. We finally reached the absolute bottom of the triage funnel. Out of the 213 patients who were cannulated in the field, 74 ultimately survived, and were discharged from the hospital. The quality of that survival is the most important metric of all. Almost 90% of those 74 survivors retained good neurological function. They walked out of the hospital with their cognitive identities intact. But during the post-study analysis, researchers found a critical caveat. This Kaplan-Meier chart compares patients perfectly meeting all inclusion criteria against those with exceptions. The high blue line maps robust survival for flawless candidates. The plunging red line tracks the grim fate of patients with missing links, like misreported bystander CPR times. This chart proves a cold medical reality. Breaking the strict triage rules, even out of compassion for a dying patient, almost guarantees that this highly expensive, resource-intensive treatment will fail. Deploying pre-hospital ECPR requires a highly specialized, elite logistical strike. Success depends on the rare alignment of perfect medical and environmental conditions. Combine perfectly optimized regional infrastructure, uncompromising medical selection criteria, and immediate bystander CPR, modern medicine has the power to reverse death on the sidewalk.